Hello everyone, myself is Sadakat and I have a bachelor's degree in dentistry and a master's in public health. And I have been associated with MYAUSSIE Tutor and academic writing since the past 1.5 years. And today's topic is arthritis and NSAIDs, how NSAIDs help in treating our arthritis and what is the mechanism of action and the pharmacology that is followed in the same. First of all, we'll describe what is arthritis, what is the normal cartilaginous balance of the body, how it gets affected due to arthritis, what happens, what is the pathophysiology behind it, and what are the symptoms that we see due to the same, and how NSAIDs help in effective relief and treatment of the same. So let's begin. First of all, cartilage is a special tissue that has viscoelastic and compressive characteristics due to its extracellular matrix, and which is made up of type 2 collagen and proteoglycans, and it consists of chondrocytes as well. It is exposed to complex remodeling mechanism, that is this matrix, extracellular matrix. Within normal conditions, it experiences complex remodeling methods by which low levels of degrading and synthetic enzymatic activity are matched to preserve the cartilage volume. A balance between the net increase of cartilage volume, which is better maintained by an increase in matrix synthesis and decreased protease, is to inhibitor ratio, and a net decrease in cartilage volume, which is better maintained by a decrease in the synthesis of the matrix, and highly increased levels of protease to inhibitor ratios exist at all times as the normal physiology of cartilage maintenance in the human body. So how then what happens that leads to the development of osteoarthritis? Osteoarthritis is most common type of arthritis. Basically causes wear and tear mostly on the joints cartilage, which is the smooth slick lining, the ends of the bones, whereby they comprise a joint. Cartilage mattresses the ends of the bones and provides for almost frictionless joint movement. And also any kind of some trauma will occur in the bone, rubbing directly against the bone, causing discomfort and limiting mobility. Injury to the joint can also cause wear and tear and discomfort and inflammation. Chondrocytes eventually expand and synthesize increased concentration of proteoglycan and collagen molecules, possibly in reaction to this failure. But even so, even as condition worsens, restorative efforts are outnumbered by cartilage deterioration. Fibrillation, degradation, and weakening begins in the cartilage's superficial layer and advances to deeper layers over time. Basically leads to significant clinically visible erosion. So in conclusion, the MMPs and the pro-inflammatory cytokines, etc., they tend to play a role in degrading the cartilage when the patient is suffering from osteoarthritis. There's a growth fiber production and secretion as well, and there is inhibitions of MMP and cytokines that seem to be insufficient to combat these degradative powers of the MMPs. The effect is cartilage loss and osteoarthritis. New therapies aimed at lowering MMP activity and increasing matrix protection are in the work. You can increase the amount of matrix being produced and you can lower the MMP activity. But certain specific ways of decombating these degradative powers are still not established. What are the clinical symptoms associated with this disease? Knee joint, the joint of the hip, and the small joints of the hands and the feet seem to be the most frequently affected joints by osteoarthritis. Patients often exhibit insidious, persistent, and increasingly deteriorating symptoms. There is pressure and swelling in the joints, exacerbated by movement and eased by rest. During the day, pain continues to intensify while stiffness tends to decrease. Deformity, decreased range of motion also arises from long-range OA, and pain management becomes a major concern. Basically, there is pain, there is stiffness, and this stiffness and pain intensity increases during the day, and its stiffness tends to decrease during the day. The stiffness increases during the night, but especially in the morning, there is morning stiffness. And there is also deformity and a decreased range of motion in specific joints where there is long-term OA. Hence, this pain management becomes the most important and the most crucial aspect of managing osteoarthritis in patients. What is the pharmacology of NSAIDs and why NSAIDs are given as the most important or the most specific contributor to pain relief in patients suffering from arthritis. FDA-approved antipyretic, anti-inflammatory, and analgesic medications are known as non-steroidal anti-inflammatory drugs, and they are used to relieve muscle pain, arthritic pain, pyrexias, etc., and as opioid-sparing medications in some acute wound situations as well. Chemical composition and selectivity of NSAIDs has been used to categorize them. They could either be acetylated or non-acetylated salicylates, propionic acids, enolic acids, and COX-2 inhibitors as well. Suppression of the enzyme cyclooxygenase is the major activity of action or the mode of action for NSAIDs to work. That is, their main mode of action is that they suppress the enzyme cyclooxygenase. Arachidonic acid is converted into thromboxane, prostaglandins, and prostacyclins by the enzyme cyclooxygenase, and the prostaglandins causes pain. When this activity of cyclooxygenase is prevented, there is no conversion of the arachidonic acid into prostaglandin, therefore causing pain. Therefore, this pain is relieved. So specifically, we're looking at MOA-Celecoxib as the first choice NSAID analgesic for arthritis and its treatment, and we're going to look at how it works. It basically works by inhibiting the cyclooxygenase enzyme specifically, and this is basically responsible for producing prostaglandin from arachidonic acid. And this prostaglandin synthesis is what causes pain, and it is a critical aspect of the pain and the consequent inflammatory pathways. If we inhibit the activity of the cyclooxygenase enzyme using celecoxib as your drug of choice for treatment, it will help in reduction in the prostaglandin synthesis and reduction in inflammatory pathway development as well. So mechanism of action of celecoxib is pretty clear, and it is pretty specific in reducing prostaglandin production and inflammatory and pain pathway that follows. The pharmacokinetics of the drug that is involved is basically the celecoxib is readily absorbed following oral injection and reaches its peak serum levels in 3 hours and metabolized in the liver, and 3% remains intact in the body, mostly excreted into the stool and urine, and it is metabolized to hydroxycelecoxib mainly by methyl hydroxylation. Its route of administration is oral via oral tablets, powders, and it can also be given topically in a very rare situation. It is a selective COX-2 inhibitor that has been linked to an elevated risk of cardiovascular disease. Its adverse effects are on the GI tract and GI symptoms are the stomach, intestinal bleeding, ulceration, perforation, vomiting. Negative impact makes it specifically risky for vulnerable people like the elderly. That is why it is not used for elderly population. Celecoxib can also induce new or deteriorating hypertension, fluid accumulation in congestive heart failure patients, and kidney toxicity and liver toxicity as well. Therefore, it is this negative impactivity helps make it more vulnerable for the elderly population, so it is not given usually. So it is contraindicated in reducing pain for patients suffering from heart disease, also in post-operative situations, cabbage, etc., and elderly population as well. And also, patients' blood pressure, kidney, and liver activity are supposed to be looked at clearly and very efficiently while you are administering celecoxib. And signs and symptoms or effects of any GI bleeding, renal toxicity, etc. And it should also not be given to patients taking antidepressants as lithium or warfarin, and their opioid doses should be tracked more closely. Plasma levels are not consistently monitored to assess therapeutic effectiveness. So we are concluding the entire thing by explaining how NSAIDs are very, very efficient in management, specifically for arthritis. What is the condition of arthritis? What are the clinical symptoms that happen in patients? And what is the physiology or the pharmacology behind this development of osteoarthritis? Most common of which is osteoarthritis, which we discussed. What are the clinical symptoms? What are the issues that the patient faces, which is basically pain management, and how NSAIDs act as an effective management without the addictive issue of the associated with opioids. So it is a useful and efficient drug. And the most common NSAID that we studied here that is used for arthritis pain management or specifically osteoarthritis is celecoxib. What is its mechanism of action, its pharmacokinetics, how it works, how it is contraindicated, etc. We can effectively conclude that celecoxib is useful and efficient drug from the class of NSAIDs, which is effectively used in pain management in cases of osteoarthritis. It helps by inhibiting COX-2 and reduces the production of prostaglandin, thereby preventing pain and inflammation. But its dosage should be effectively monitored by the nurses and the physician in order to prevent any complication. Thank you. I hope you've understood the entire thing. I hope to see you next time again.